Let's talk about staging of anal squamous cell carcinoma. The American Joint Committee on Cancer has come up with staging algorithms for both anal margin malignancies as well as anal canal cancers. And essentially they're staged the same way in terms of the T stage. A T1 lesion is less than 2 centimeters, a T2 lesion is between 2 to 5 centimeters, and a T3 lesion is greater than 5 centimeters. And that's whether you're talking about an anal margin lesion or an anal canal lesion. Similar to the way breast cancer is T-staged. Now, a T4 lesion is also described for both anal margin and anal canal lesions, and that indicates involvement of deeper tissue. So, for example, if you have a 1 centimeter lesion within the anal canal, but it involves the internal or external sphincters, then it's automatically a T4 lesion. And when we talk about the lymph node status, N0 disease, of course, both for anal margin cancers as well as anal canal cancers, indicates that there's no lymph node involvement. But N1 disease for anal margin cancer indicates that regional nodes are involved with metastatic squamous cell carcinoma. The end staging for anal canal proper malignancies is a little bit different. If you have perirectal involvement, then that indicates N1 disease. If there are perirectal involvement in conjunction with unilateral inguinal node involvement, then that's N2 disease. And if you either have bilateral inguinal node involvement or unilateral inguinal node and perirectal involvement, then that would be considered N3 disease. Treatment for anal margin cancers, as long as they're early stage, T1 or T2 lesions, is wide local excision with a 1 centimeter margin. And if you look at some of the older series actually that evaluated wide local excision of carcinoma in situ and T1 lesions that were treated with wide local excision, the survival was 100% and the local recurrence was 0%, particularly from a study by Barris and Wilson in 1976 that showed that data in a series of 27 patients. Even for anal margin lesions, if you have a less favorable lesion, one particularly that's a T3 greater than 5 centimeters or 4 involving the deeper structures, then you would consider chemoradiation as primary therapy. Now, in contrast, when we talk about treatment of anal canal squamous cell carcinoma, then chemoradiation is the modality of choice. And this is based on the work of Nigro, who published his research in 1974, essentially showing that a combination of external beam radiation, in his study he used 30 gray, combined with 5-FU and mitomycin C, shows really exceptional results and 5-year survival on the order of 80%. There have been 2 controlled, well-done, randomized studies, one by Bartlink, another by the UK Cooperative Committee on Cancer Research, that show that chemoradiation, as opposed to radiation alone, provide for a superior results in terms of local recurrence. One of the more preferred protocols for administering chemoradiotherapy is to provide between 45 and 54 gray of external beam radiation in combination with 5-fluorouracil, and instead of mitomycin C, cisplatin, which has the advantage of being a better radiosensitizer and is also less immunosuppressive, or myelosuppressive particularly.